Assalamu alaikum. This is the second spine trauma lecture according to regional spine trauma types. I am Samir Kitab, orthopedic spine surgeon. Now, as we said, the craniocervical junction is mainly stabilized by ligamentous elements that consist of the apical alar ligaments and the cruciate ligament. Most of injuries that occur in the craniocervical junction are due to ligamentous disruption because of over-distraction or flexion distraction or extension distraction injuries that will injure the stabilizing ligaments of the craniocervical junction. An axial compression force might fracture the occipital condyles, and this is usually due to high energy trauma associated with cranial trauma, skull base fractures. These patients with craniocervical injuries might present with lower cranial nerve palsies, most commonly involvement of the cranial nerve number 12 with additional upper cervical spine injuries. Usually these injuries are associated with high mortality rate because of the position of the medulla oblongata, which contain the vital centers, neurological vital centers, and involvement or injury to the medulla oblongata is usually fatal. This slide shows how distraction injuries, axial distraction injuries, or flexion distraction injuries, or extension distraction injuries that may injure the ligamentous structures of the craniocervical junction, which are elaborated on the slide on the right side. Upper cervical spine injuries or craniocervical injuries with distraction. Here in this situation, skull traction is contraindicated. If the patient survives the injury, the skull or the craniocervical junction should be rigidly immobilized with careful evaluation and the stabilization of the craniocervical junction. So traction is contraindicated in this type of injury because of ligamentous disruption. After initial assessment of the patient and initial assessment of vital signs, ensuring patent airway, breathing, and adequate circulatory volume or adequate circulation. Now, image investigation of a spine injured patient usually consists of plain x-rays should be taken in the two planes, anterior-posterior and lateral views, but due to the complex anatomy of the upper cervical spine and the craniocervical junction, screening CT scan is rapidly replacing plain radiography as the initial imaging study in the evaluation of cervical spine trauma. The complex anatomy provides the principal advantage of CT over X-ray, and CT is able to delineate bony anatomy with superb spatial resolution and detection of bony injuries with 100% sensitivity. It is helpful to identify and characterize fractures in the upper cervical spine and the craniocervical junction. There are various radiologic lines that delineate the bony anatomy or the spatial resolution of the bones at the craniocervical junction and the C1, C2 complex. These include the Chamberlain line, the other lines that need the lateral masses, the odontoid and the occipital condyles, and so on. And CT on the right side, here it shows the anterior dento-atlantal interval, ADI, and anterior dento-atlantodental interval. That is the interval between the anterior arch of the atlas and the dens. Behind is the posterior atlantodental interval. That is the posterior space between the posterior edge of the odontoid and the posterior arch of the atlas, and this is more important than the anterior atlantodental interval because it measures the space available for the spinal cord behind the odontoid process. And another parameter, that is the basin dental interval, and this is useful in detecting craniocervical injuries with ligamentous destruction or distraction injuries of the craniocervical junction. To delineate the integrity of soft tissues, including ligaments and the intervertebral disc and in neural structures, MRI is very useful. So MRI is indicated in the presence of neurological deficit. It is a must. If there is clinical suspicion of ligamentous or disc injury because of the ability of MRI to delineate the integrity of soft tissues. If the patient requires surgical intervention, MRI is a must so that we can know the relation between neural and the skeletal elements. MRI can help in the evaluation for causes of a neurologic deficit, such as the degree or type of intrinsic spinal cord injury, canal stenosis, and the direction of the canal stenosis, whether it is anterior or posterior, or whether there is an occult vascular injury, especially in the cervical spine. Magnetic resonance angiography is helpful to delineate the anatomy of the vertebral arteries. If the patient has disc disruption with disc compression or herniation that is compressing the spinal cord or nerve roots, and whether the patient has a spinal cord hematoma or hematoma in other places. And MRI can differentiate between spinal cord transection, contusion, and hemorrhage, and the various time intervals when there is parenchymal hemorrhage of the spinal cord, whether it is acute or subacute or it is delayed parenchymal hemorrhage. The extent of areas involved or the extent of area of the spinal cord that is involved again can be visualized in a patient with a spinal cord injury. As we said, the C1 ring acts as a spacer or a washer between the C2 and the skull or the base of the skull. And C1 ring fractures usually occur due to an axial compression force with either axial compression force with a flexion or with extension, or pure axial force that might injure the anterior arch, posterior arch, or both of them, that we call them a Jefferson fracture, four-part fracture. Now, these fractures, particularly the isolated posterior arch pattern, are commonly associated with C2 fractures, most commonly type 2 odontoid fracture and Hangman fractures, and we will see or in the next slides more elaboration about odontoid and Hangman fractures. Neurologic compromise is rare, as we said, because of the large space available for the spinal cord, and the injury usually causes lateral displacement of the ring of atlas, so that the injury causes decompressive effect rather than compressive effect of these fractures because of lateral displacement of the ring or the atlas ring. Now, most of atlas ring fractures can be treated with rigid immobilization for 6 to 12 weeks because they are bony injury. Most anterior and posterior arch fractures and lateral mass fractures can be treated conservatively. An important view that can delineate the integrity of the atlas ring fracture and the relation between the atlas lateral mass and the axis that is marked here in red lines. The stability of the atlas ring and the stability of the C1, C2 complex, because the C1, C2 mainly is concerned with lateral rotation of the cervical spine. 50% of rotation of the cervical spine occurs at C1, C2 complex. So if we have a ring fracture of the atlas, most of these fractures are stable and can be treated conservatively, as we said. But if we have disruption of the transverse ligament that connects the lateral masses of the atlas ring, this is an unstable injury. Why? Because disruption of the transverse ligament will cause posterior displacement of the odontoid process with impingement of the spinal cord or the medulla oblongata, and this is serious and cause neurological injury. So how can we tell that the transverse ligament is injured? In an open mouth view, however, it is a static view. If the lateral masses of the atlas are displaced away or laterally from the axis of more than 7 to 8 millimeters, this indicates disruption of the transverse ligament, and this is an unstable injury and should be treated operatively. Another way to delineate the integrity of the transverse ligament is that we take a lateral view with some flexion and extension. This is should be done carefully. If we have an enlarged anterior and atlantodental interval of more than 3 millimeters, it indicates disruption of the transverse ligament. Or if we have reduced posterior atlantodental interval less than 17 millimeters, again it indicates posterior displacement of the odontoid with possible impingement on the spinal cord. So the key to treatment of Jefferson fractures, which is four-part fracture, is determination of the integrity of the transverse ligament. And these radiological means are mainly concerned with the determination of the integrity of the transverse ligament that stabilizes the atlas and the odontoid and the atlantoaxial complex. Another type of injury that occurs in the axis or the second cervical vertebra is what we call Hangman fracture. Hangman fracture is fracture of the pars interarticularis of the dens or the pars interarticularis of the axis vertebra or the second cervical vertebra. They are usually occur because of extension compression injuries that will fracture the pars interarticularis of the second cervical vertebra. And with this fracture, there will be either spondylolisthesis of C2 over C3 or angular olisthesis, yani slipping with angulation of C2 over C3. And this is what we call Hangman fracture or traumatic spondylolisthesis or slipping of C2 over C3. Traditionally, since this is bony injury, treatment is conservative with extension brace or extension or traction and extension to approximate the fracture surfaces. With this traction is a prolonged reduction traction for days to weeks, followed by 12 weeks of halo immobilization. As we said, Hangman fracture is because of extension compression injury that will fracture the pars interarticularis of the C2. This X-ray in the middle showing the fracture line in both parts, and it has fielding or Michael Feeling classified this fracture into 4 types. And treatment consists of cervical traction to improve the displacement and immobilization, and later immobilization in hollow vest. The odontoid process can be fractured, and this fracture occurs due to high energy trauma in young patients, while a simple fall can injure the odontoid process in the elderly. And in the elderly population, this injury is associated with an in-hospital mortality rate of 35%, with high mortality rate. Usually these patients are over 80 and they get fracture of the odontoid process with possible neurologic injury. Now, there are three types of odontoid fracture. A fracture that occur at the tip of the odontoid process, and this is usually due to ligamentous avulsion because of an avulsion of the apical ligament. This type 2 fracture is a fracture that occurs through the waist or the base of the odontoid, and it has a high risk of non-union because the odontoid waist is mainly consists of cortical bone, and this fracture can be displaced or angulated or associated with movement and precarious blood supply. All of these will predispose to non-union this type of fracture that occurs through the waist of the odontoid process. If the fracture occurs through the base of the odontoid, through the cancellous bone, that does not involve the C2 superior articular process, and this is what we call type 3 fracture. Type 3 fracture. Type 3 fracture, since it occurs through cancellous bone, it is amenable to healing with conservative means or with traction, with hollow immobilization. Now, fractures that occur through the waist of the odontoid is associated with higher rates of non-union, especially in fractures with initial displacement greater than 5 millimeters or angulation between the fractured pieces greater than 10 degrees, or with posterior displacement of the proximal fragment. In patients older than 50 years, these factors, because of the trauma, act as an indicators for surgical treatment. So surgical treatment is strongly indicated if we have these risk factors: greater than 5 meters displacement, angulation greater than 10 degrees, posterior displacement of the odontoid fragment, and in patients older than 50 years of age. Now, the X-ray on the left side showing an odontoid screw. This screw is inserted through an anterior approach. We approach through C5-6 level, and then we proceed under screen. Usually we use 2 screens at the same time that show the anterior posterior view and lateral view, because this is not an easy procedure. This screw is lag screw that will cause compression of the fracture surfaces. So we reduce the fracture and we insert the screw to stabilize the fracture. So insertion of this screw will preserve the C1, C2 articulation. The CT on the right side showing how we evaluate if there is displacement of the fracture, how many millimeters it is displaced, or angulation, how many degrees it is angulated. In a patient with displaced fracture more than 5 millimeters or angulation more than 10 degrees is an indication for operative or surgical fixation of the fracture. Now, in pediatric patients, C1 and C2 can undergo subluxation that is rotatory. So that is rotatory. That means that C1 will rotate over C2, or C1 will undergo rotatory subluxation over C2. There are 4 types, and this is usually seen in pediatric patients because of an inflammatory process or because of a trauma. The cause is usually, if the cause is inflammatory, it is called Grisel syndrome. And the inflammation is because of close approximation of the C1, C2 complex to the pharynx and retropharyngeal space. A pediatric patient might present, or child might present with torticollis, painful torticollis, that is associated with pharyngitis or tonsillitis or upper respiratory tract infection. And this is due to an inflammatory process that causes capsular laxity and rotatory subluxation of C1 over C2. These are the 4 types described by Fielding classification of Grisel syndrome. Now, a child might present with torticollis because of the inflammatory rotatory subluxation over C1 over C2, and this is called cock-robin position. Cock-robin position. The 3-dimensional CT in the lower image showing how the C1, C2 is subluxated, and the CT on the right side showing rotatory subluxation of C1 over C2, and this will predispose the patient to develop torticollis or painful torticollis. Injuries that occur below C2, we call them subaxial injuries. And subaxial spine are all the spine below the axis, that is C2. So they call them subaxial injuries. And since we are concerned with the cervical spine, now subaxial cervical injuries occur because of flexion compression injury, flexion compression force that will compress the vertebral body. So I will cause compression injury or compression failure of the anterior vertebral body. But in compression fractures, the vertebral body is involved while the posterior ligamentous complex is not involved, or it is intact. The photo below depicts how we classify or we divide the spine into 3 columns. And this is concerned with the stability of the spine in a patient with subaxial compression injury. So we have an anterior column, that is anterior 2/3 of the vertebral body, the middle column, that is the posterior 1/3 of the vertebral body, and we have the posterior column, which is mainly posterior osteoligamentous or ligamentous elements, posterior ligamentous elements. And if we have a fracture that is causing flexion compression or compression of the vertebral body with preservation of the posterior ligamentous complex, that is the posterior longitudinal ligament, ligamentum flavum, the interspinous and the supraspinous ligaments. Ligamentum, or the posterior longitudinal ligament, is usually concerned with the middle column. The posterior ligamentous complex consists of the ligamentum flavum, facet capsule, interspinous ligament, and the supraspinous ligament. So if this posterior ligamentous complex is not injured, the fracture is stable and the vertebral body is wedged on X-ray, but there is minimal kyphosis. And since the fracture does not involve the middle column, there will be low risk of spinal cord injury, because the middle column is mainly concerned or is near the neural structures, the spinal cord. Now, what we was describing is wedge compression fractures of the vertebral body that involves the anterior two-thirds of the vertebral body. That is the anterior column. Now, if the fracture involves the middle column, that is fracture involving the anterior and middle column, this is called burst fracture. So why we divide them into burst or wedge fractures? Burst fractures involving the middle column, and the middle column is nearby neural structures near the spinal cord. So it indicates a higher grade of energy, of higher energy of trauma, and indicates a high grade of trauma to the vertebral body and failure of the vertebral body. So cervical and subaxial burst fractures occur primarily via axial load with or without flexion compression, or without flexion, and associated with subsequent compressive failure of the vertebral body. So since the fracture involves the middle column, you may have bony or disc retropulsion into the spinal canal. They are usually unstable and associated with cervical cord or spinal cord injury. If the fracture that is involving the vertebral body is associated with posterior ligamentous complex injury, this is unstable, mechanically unstable burst fracture. If the fracture or if a burst fracture is associated with a neurologic injury or spinal cord injury, this is again a neurologically unstable fracture, and these unstable fractures are indications for surgical treatment. So we have stable burst fractures and unstable burst fractures. Now, these are flexion compression or axial compression injuries, and the MRI on the right side, we see that the vertebral body is failing at the anterior and the middle columns, with the bone is retropulsing and causing pressure effect on the spinal cord. The spinal cord, there's increased signal intensity within the spinal cord, indicating spinal cord injury or contusion or hematoma formation. And there is spinal canal stenosis because of retropulsion of bone upon the spinal cord. In this fracture, the patient might present, or this patient might present with neurologic deficit that is, or should be assessed with ACS scale score, as we said before. And this is a neurologically unstable trauma, and it is an indication to do surgery or surgical intervention. If the patient has concomitant posterior ligamentous complex injury, this is mechanically unstable fracture, and it should be treated again by or with surgical stabilization. Surgical stabilization in a patient with a neurologically unstable fracture, that is a fracture associated with neurologic deficit, consists of surgical treatment, and it is according to the type of injury. In this fracture, the vertebral body is removed, what we call corpectomy, with fibular graft is inserted, and plating was done from the anterior approach, and lateral mass fixation from the posterior approach. In a patient with an intact neurological status, if the fracture is stable, that is a fracture or burst fracture that is not associated with posterior ligamentous complex injury. When the posterior ligamentous complex consists of the facet capsules, ligamentum flavum, interspinous and supraspinous ligaments. If these ligaments are intact, the patient has a burst fracture, there is a place for conservative treatment in the form of bracing or brace or traction for these patients. Surgery is not needed in these patients. So what we described in the previous slides are cervical spine injuries because of flexion compression injuries or axial compression injuries. So if the patient sustained a flexion distraction injury, this will cause disruption of the stabilizing elements that consist of the intervertebral disc or the facet joint capsule. So these patients, usually because of flexion distraction injury, they present or represent a broad spectrum of bony and soft tissue injuries ranging from subluxation to dislocation of the cervical or the injured cervical vertebrae. There is possible involvement of the intervertebral disc, involvement of one or both facet joints, that is the facet capsule is disrupted or the facet itself is fractured, and these injuries will cause subluxation or spondylolisthesis or slipping of one vertebra over the other because of the distraction force of injury. So if the lateral view of the cervical spine showing subluxation, that is 25% of the vertebral body, this is usually due to unilateral facetal subluxation or dislocation. If the subluxation or slipping of one vertebra over the other is more than 50% of the width of the vertebral body, usually this indicates bilateral facet dislocation, and this is a serious injury usually associated with a spinal cord injury, and most of these patients present with complete spinal cord injury. Flexion distraction injury will cause unilateral or bilateral facet dislocation. So starting these photos, starting on the right side, now what we see at the right upper photo depicting a bilateral facet dislocation. Why? Because there is a slipping of one vertebra over the other more than 50%. Now the scheme on the top right picture showing one facet is dislocated over the superior articular process of the upper vertebra is dislocated and perched over the inferior articular process of the lower vertebra. So unilateral or bilateral facetal dislocation will result in spondylolisthesis or slipping of 25 to 50% of the vertebral body over the other. This is associated with either nerve root injury or spinal cord injury. Now, initial non-operative treatment consists of application of an incremental weight traction to the skull through the application of skull traction, as is shown in the picture below, and an initial 10 to 15 pounds of weight is applied, sequentially increased in 5 to 10 pound increments with careful neurologic evaluation. This is usually done in a conscious patient who can cooperate, and so that we can assess the neurological status of the patient, if the patient develops weakness or neurological symptoms consequent upon skull traction. So neurological examination is performed, and this is usually done under C-arm X-ray control and screening, and radiographs are obtained after each incremental weight. So if the distraction between the vertebrae increased to more than 1 cm, this is usually stopped, or if there is subsequent neurologic manifestations. So each increment weight increase to ensure that the patient neurological status is stable and that the level of injury is not over distracted. Subaxial fractures, including the thoracolumbar level. Thoracolumbar level is from T10, 11 or T11, 12, L1, L2. So it is from T10 to L2, T11, 12, L1, L2. This site is a junctional level. It means it is a transition zone between the rigid thoracic kyphosis that is made rigid by the rib cage and the mobile lumbar spine. So this level is frequently involved with injury. And in the young patient population, high energy mechanisms such as a fall from height or motor vehicle accident, these are the usual mechanisms of injury. In elderly patients, a fall from standing height can be significant to cause osteoporotic compression fracture, especially if the patient has osteoporosis. Now, in this region, the rigid thoracic spine transitions into a more mobile lumbar spine. And that is why this site is frequently involved with spine injuries. Overt stability elements that we had discussed in subaxial spine injuries apply here. So if we have a wedge compression fracture or a burst fracture with an intact posterior ligamentous complex, this is usually a mechanically stable fracture and can be treated conservatively. While burst fracture with concomitant posterior ligamentous complex disruption or injury is mechanically unstable fracture, and this is indicated for surgical treatment. Now, a patient with a thoracolumbar injury or fracture with a neurologic injury, again, it is one factor in the decision making to do surgery. Now, the benefit of surgery is neurologic decompression. So we decompress the spinal cord or the coda equina or the conus medullaris if there is an element of compression, for example, a retropulsed bone fragment or disc that is compressing the neural structures. So in this is an indication for surgery, or if the patient has a mechanically unstable spine because of the trauma, and the trauma that involves the anterior column or the middle column associated with posterior ligamentous complex disruption or injury. So the posterior ligamentous complex is an important component when determining the stability or the mechanical stability of a fracture. The PLC is composed of the facet capsules, ligamentum flavum, interspinous and supraspinous ligaments. They are the posterior tension band of the subaxial spine. As we discussed in the first lecture, the spinal cord ends shorter than the vertebral column. That's why the spinal cord segments do not coincide with vertebral levels, as is shown in the picture here. Now, the spinal cord ends at the lower border of L1 or the upper border of L2 in a region we called conus medullaris. And the conus medullaris is the region of the spinal cord at which lumbosacral segments are condensed. So injury at this level will cause neurologic manifestations in the lower limb as well as visceral neurologic deficit, because the parasympathetic innervation to the viscera is from the sacral segments. So involvement of these sacral segments may cause bowel or bladder or urinary tract symptoms in the form of flaccid bladder and urinary retention. So the normal spinal cord terminates in the conus medullaris at L1 level, which means the spinal cord is at risk of injury throughout much of the thoracolumbar junction, that is between D10 to L2. The spinal canal diameter in the dorsal spine is relatively narrow and therefore not able to tolerate significant canal compromise. Thoracolumbar fractures range from compression injury with wedge-like deformity in the vertebral body. These are usually due to axial compression associated with flexion component, flexion compression injury. If the patient sustained an axial compression injury, we may get a burst fracture, and this is due to involvement of the middle column of the spine. That is the posterior 1/3 of the vertebral body. And this is important because disruption in this column will cause or might cause a neurologic injury. Now, if these fractures occur with intact posterior ligamentous complex, they are rather mechanically stable. However, chronic instability cannot be guaranteed, because these patients might drift into kyphosis, and kyphosis begets kyphosis. So in the long term, these patients might develop more kyphosis because of the vertebral or anterior element injury. Now, if we have disruption of the posterior ligamentous complex associated with rotational or distraction injury, this will cause translation or rotation of the injured segment. And rotation or translation of the injured segment or distraction, this is serious injury and will definitely cause mechanical instability with high rate of neurologic injury, and these patients should be stabilized surgically. As we said, the benefit of surgery is neurologic decompression, especially if we have spinal cord compression, or if it is below L2, we may get lower motor neuron affection in the form of coda equina compression. So the compression of the lumbosacral roots that will form the lumbosacral plexus. Now, if the compressive elements are anterior and they are causing pressure on the spinal cord or the coda equina, anterior surgery may be utilized or is frequently indicated for an incomplete spinal cord injury or coda equina injury resulting from retropulsed bone due to a burst type fracture. Burst type fracture is a fracture that involves the anterior and the middle columns of the spinal or the middle columns of the spine. So approaching the spine anteriorly, for example through thoracotomy or thoracoabdominal approaches or retroperitoneal flank incision, we expose the vertebral body. We do subtotal removal of the vertebral body, that's subtotal corpectomy, with the removal of retropulsed bone, and this is effective in decompressing the spinal canal. Now, corpectomy or vertebrectomy, removal of the vertebral body, will leave an empty space or a void in the anterior column. This is reconstructed with either bone graft or expandable cage that is made of titanium cage that we can expand intraoperatively to correct kyphosis because of trauma. And we can do again an instrumented instrumentation, so that the spine will be stable and the anterior column is reconstructed. And this is done from an interior approach. Most of the time we utilize posterior approach. We approach the spine posteriorly, as in this photo. Approaching the spine posteriorly is again effective in decompressing the spinal canal, especially if we go laterally and we approach the spine from an extracavitary approach, for example, extrapleural or through costal transversectomy, or rather posterolateral approach to the anterior elements of the spine. So we can do laminectomy, we can resect the pedicle, and we can do vertebrectomy from a posterior approach. In addition, we can reconstruct the anterior column and stabilize the spine through pedicle screw system, as is shown in this picture, all from a single approach, a posterior approach. The limitation in the anterior approach is that we cannot put such an instrument or such amount of fixation anteriorly because of the proximity of the great vessels, while posteriorly we can stabilize the spine. For example, as in this case, we are putting 2 levels fixation above and 2 levels below with a cross connection. So direct decompression can be achieved from posterior approach by removing the facet, lamina, pedicle, ipsilateral to the retropulsed bone, and removing the fracture fragment, or tapping it anterior. We can tap it by Woodson impactor and hammer. The spinal canal has the potential to remodel as it heals with increased spinal canal diameter over time. Thank you.